Yeah, so as Jeremy mentioned, this presentation is really a very basics approach and an all-encompassing look at hip and knee arthroplasty. Jeremy did an excellent job putting together a lot of the foundation of this. And as I was going through and making some of the edits and finalizing things, my objective with this was to try to provide kind of the hip and knee talk that I always wish I had as a student, basically. Obviously, hip and knee arthroplasty are very bread and butter cases that you will see in any orthopedic rotation. And so having just really the bare minimum foundation and getting comfortable with the terms, I think, is the first place to start if you want any chance of understanding some of these concepts that can get actually quite abstract and challenging pretty quickly. So hopefully we can accomplish that today. So our agenda today is really split up into two. So looking at the total knee side of things, we'll do introduction and basics to start, then surgical approaches and technical considerations, and then complications to follow. And then we'll do basically a similar paradigm for total hip afterwards, and we'll leave some time for questions and discussion. I may ask a couple just open questions as we go to try to keep things interactive, but certainly no pressure either way on those either. So some objectives. With total knee, you can see kind of we'll set the foundation at first. So understanding basic principles of surgery, appreciating the general goals that we hope to achieve when we do a total knee, and then introduce some of the concepts in knee alignment. Then when we transition to talk about the actual surgical management, we'll try to appreciate the basic workflow. Then hopefully we can teach you how to recognize the connections between operative steps and the above concepts. And then we'll lastly finish off with complications, namely aseptic loosening, arthrofibrosis, and a bit about PJI. With total hip, it'll be similar, but as you'll notice, there's a few key differences, whereas in the foundation section, we'll talk more about hip stability rather than alignment. And tying that in with the surgical management, how the different surgical steps play their role in achieving hip stability and preventing complications. And again, that follows through when we talk about complications later on as well. And we'll also say a word about periprosthetic fractures, which are something that are becoming increasingly common as arthroplasty is being performed at a higher rate with an aging population. So jumping right into things, at its very basic core, total knee arthroplasty is just replacing the three articulating surfaces of the knee by removing the bone and replacing them with similar sized implants. So these three articular surfaces being the distal femur, the proximal tibia, and the posterior aspect of the patella. And our objectives, stating them simply here. So one, of course, pain relief. Two, restoration of function. As people get progressively worse deformities, they can start to experience knee instability, flexion contractures, and obviously difficulty with ambulation, traversing stairs, and completing their activities of daily living. Surgically, we aim to achieve a well-balanced knee that will help confer longevity, provide stability, and ultimately patient satisfaction. And as a more concrete thing to try to aim for, we look to try to achieve functional range of motion, which we define as about 0 to 120 degrees. So that's a straight knee to one that bends about 30 degrees past 90 degrees. That will allow you to complete most of your activities of daily living, sit in most chairs, and traverse stairs comfortably. A bit about the native anatomy and kinematics of the knee. So some terminology to be aware of. First, we'll start out with the mechanical limb axis, which is represented by a line drawn from the center of the femoral head to the center of the ankle down here. This line through the knee joint passes just medial to the tibial spines. And we have a similar terminology when we look at each individual bone, like the femur and the tibia. So in the femur, the mechanical axis, similarly is from the center of the femoral head down to the center of the knee joint. And in the tibia, similar to what we had prior. However, the anatomic axis of the femur and tibia are kind of the unique terms here that we don't really use when talking about the limb as a whole. In the tibia, it's quite simple. The anatomic axis and mechanical axis are really one and the same, essentially. In the femur, though, there is a little bit of variation. So the anatomic axis, so the line bisecting the femoral canal, is about 6 degrees off from the mechanical axis of the femur. And this becomes even a little bit more complicated when we start considering the angle of the joint line itself. So as you can see, this blue line represented in the rightmost image on the top. This joint sits where many joints sit, which is in about 3 degrees of varus alignment. So instead of being a flat perpendicular to the mechanical axis of the limb, it sits in about 3 degrees. So in fact, the anatomic axis of the femur sits in total about 9 degrees, what we call valgus, from this joint line from the joint line perpendicular here. A bit a bit more about distal femur anatomy. So the medial and lateral femoral condyles are not truly one and the same in terms of their geometry. So there's a bit of asymmetry there. And the lateral femoral condyle is a bit smaller in the A to P direction. And when you look at the center of rotation, so if you kind of imagine a circle over these condyles here, as the knee bends, the lateral femoral condyle doesn't actually rotate along one fixed point the whole way. There's actually two circles that it rotates along as the knee goes into further flexion, whereas the medial femoral condyle is a bit more concentric. So what happens is as the knee begins to bend, you have a bit of a screw home mechanism where there's a rotational aspect at the joint as well. Furthermore, as you bend back, it's not a true hinge all the way through. So as you get into deeper flexion, instead of just rotating in one fixed point, the femur actually starts to translate posteriorly, and that allows the femoral condyles to clear the tibia and allow for more anatomic knee flexion. Last thing I really want to say on this, so a few years ago, there was this classification system that was published on, has become popularized in the arthroplasty space, and we call this the coronal plane alignment of the knee classification, or the CPAC classification. Getting into the specifics about kinematic and mechanical alignment is really beyond the purposes of this talk, but I did want to introduce these concepts because they are things that you may see if you're listening to arthroplasty folks along your rotations. And I'm going to show you here just kind of an image that's published from the index paper on this. So this group, not to get into the weeds too much here, basically what they did is they classified different knee morphologies. And so looking at just a couple examples here, just to give you a sense of what's going on here, what they were aiming to describe was that not everyone's knee is built the same. People have different degrees of joint obliquity. So some have very straight across or perpendicular to the floor joint angles, whereas some have more varus or valgus knee angles. And then furthermore, that's different than the actual angle of the knee itself. So when we talk about having a varus knee, as demonstrated here in this top left, or a valgus knee on this top right, that is kind of separate altogether from the actual obliquity of the joint line. And the reason this has gained popularity is because people have seen, and we'll touch on this a little bit as we get into coronal alignment later on, that classically, the goal of knee arthroplasty was often to basically recreate a mechanically perpendicular joint line. So if we go back real quick and look at this mechanical axis, you can imagine it would at least be conceptually simple to recreate a knee replacement where the joint line that you're creating artificially is perpendicular to a straight up and down. It's a little bit easier to aim for that and reference it off the tibia rather than try to create an oblique angle. It also is conceptually a little bit more palatable when you think about, hey, if I'm putting in implants like sideways, couldn't that confer some shear loading on those implants as the years go? But in fact, as arthroplasty evolved over the years, people started to see that you can actually, there's kind of a whole school of thought that looked and said, hey, well, if someone's joint line is natively a few degrees off from a perpendicular to their mechanical limb axis, then maybe we shouldn't be trying to artificially create this perpendicular joint line. Maybe it's actually beneficial to put in a bit of joint line obliquity to match their native anatomy. And then long-term studies have been published now that have shown that, in fact, that can be quite successful for many patients and perhaps even beneficial in some ways. So, and not to get too far into the weeds on this, but just these are some terms that you may see, and hopefully this provides just a little bit of a base that you can look into further on. So now talking into some basic surgical steps here. Preoperative management for knee arthritis consists mainly of physical therapy, activity modifications, and weight loss, which can really be quite effective because the knee sees, I think, anywhere from about a 3 to 5 multiple of your body weight when you are walking or traversing stairs. And so just a little bit of weight loss can actually take off quite a bit of force off the knee. Oral medications like anti-inflammatories, Tylenol, and even duloxetine has some indications for treatment of arthritic pain. And then injection therapy can be helpful as well. If any of you have done an orthopedic rotation, you'll notice I didn't mention other types of injections. So corticosteroids are kind of the tried and true method that has remained a mainstay in conservative management. Hyaluronic acid or gel injections, as you may hear them called, have been popularized in the past, but actually recently have received a AAOS clinical practice guideline against their use. Conversely, PRP actually in recent years has gained a little bit more favor in this space. And so you may see this change even during your own training. But just know there remains a persistent role for corticosteroid injections, and various injection modalities beyond that are kind of coming and going in a fluid nature. And then I kind of mentioned miscellaneous here. So sometimes you will see people empirically use like what are called unloader braces. So imagine basically a knee brace that is seeking to kind of push this knee out of varus alignment. There are other modalities through pain management, like genicular nerve or genicular artery embolization. These are things that are really much more esoteric, not things you would come across commonly. And then I mentioned your arthroscopy too. I think the general treatment paradigm is we don't typically scope arthritic joints, but there is some literature that suggests that really with mild or minimal arthritis, and especially in younger patients, there may be some role in management for arthroscopic debridement, partial meniscectomies, as ways of just temporizing patients' pain until they're a bit older and a more reasonable candidate for a total joint arthroplasty. When we look at preparation for total joint, so it is important to consider the various arthritic etiologies. So it's not always osteoarthritis. Some patients may have rheumatoid or inflammatory arthropathies. Some patients may have post-traumatic arthritis. And these are important in that they may play a role in your surgical planning. With rheumatic disorders, there are actually recommendations along holding their DMARD therapy for certain lengths before and after surgery. So just things to consider. Also, you do kind of get to play that role of a physician in a greater sense beyond just kind of their orthopedic surgeon, in that arthritis may have different forms of arthritis can have characteristic appearances. And so you may actually be the first presentation for a rheumatoid patient and can get them plugged in to seek appropriate care and maybe help prevent joint disease in other joints down the line by just getting them plugged in with a rheumatologist. Weight-bearing radiographs are important. So here you can see a comparison between a non-weight-bearing and a weight-bearing image. Granted, this one seems like it's a bit more flexed here, almost like a Rosenberg view, but there are really significant differences in weight-bearing and non-weight-bearing view. So you just want to be mindful of that. And then setting expectations is important. Even though, we think of this as a joint replacement, you're not really achieving a anatomic joint for patients that they can go out and just do whatever they want. Doing high impact activities may be poorly tolerated. Their knee range of motion will not quite be the same as a normal knee. Setting expectations for their post-operative course, total knees can be quite painful. So giving them a sense of what to expect in that regard, and getting things in place to set them up for success in the first few months after their surgery are really, really vital parts of the surgical steps here. So now, giving you guys just a general overview of the total knee surgical steps. So looking at approaches, generally you'll see midline incisions done for this. There are various kind of forms of this that have been published on in recent years. Some people do more minimally invasive approaches, but typically I think the tried and true bread and butter thing you'll see most often is just a midline incision of the skin. Then as we take that down and we get to the knee capsule, by far, I think the most common thing you'll often see is what's called a medial parapatellar arthrotomy, which is demonstrated here by line A. But there are variations of this that exist, such as mid-vastus or sub-vastus approaches, and very, very rarely lateral parapatellar arthrotomies. These are what we call kind of primary knee approaches. There are more extensive approaches, such as tibial tubercle osteotomies, or actually snipping the quadriceps tendon in some ways. For like revision knee. But again, at kind of its basics, you should really be familiar with the medial parapatellar arthrotomy as kind of the workhorse approach. And then after that, you have to expose the knee joint. So this is done by a variety of soft tissue releases, like releasing the medial capsule off the knee, any kind of synovial plica, which are kind of fibrous adhesive bands that may have formed. There's a fat pad that lives behind the patellar tendon that people may resect to varying degrees. There's also a suprapatellar region that has a fat pad and kind of a synovial reflection that often gets released. So you have to do all of this to really try to open up the knee and eventually get to a point where you can either sublux the patella, or excuse me, dislocate the patella, or even flip and evert the patella and move it out of the way, because you need basically full exposure of the distal femur and the proximal tibia to do the rest of the surgery. Then you'll see bone cuts being made, and these can be made in varying orders depending on the system and the surgeon. Generally, we divide these up as what's called a distal femur cut, and you'll see these diagrammatically displayed later. And then a proximal tibia cut, and then what we call the anterior, posterior, and then these kind of oblique chamfer cuts at the distal femur. And then there are medial and lateral as well as posterior soft tissue releases. And these, again, are done in varying orders, but these are kind of the basic steps that as you watch your first total knee, you kind of should be able to start to gain a sense of, okay, he's cutting the distal femur now, and okay, she's now releasing the medial tibia. And just getting these things in your head will help stay on track and follow along with the surgery a little bit easier. And then you can learn kind of the surgeon-specific steps that go in line with their system. As you can see here, when you make these cuts, you have to reference off of their native anatomy. So this is an example of what we call intramedullary referencing. So this handle, actually rod that actually extends into the medullary canal of the femur. And then all the kind of various jigs that you see here have different degrees of freedom that allow you to cut at various angles to various depths. And so this is kind of part of this is, again, surgical planning and then surgeon preference. Eventually, at some point, you just make cuts to kind of a consistent degree based on your system and what implants you're using. Then you adjust along the way as you go with different soft tissue releases. And, when you make your femoral cuts, you can then make up certain ways with your tibial cut and vice versa. And then once you've made your appropriate cuts, you will then trial implants. So you put in temporary distal femur, proximal tibia, and polyethylene implants. You'll assess the stability and the range of motion of the knee, and then you can make some final adjustments at that point, and then put in your final metallic implants. And then as kind of a final check, you can actually change the size of this polyethylene implant to tighten up or loosen up the knee further. When you fixate these implants to bone, they're often done with cementation, which we'll talk a bit more about when we do total hip as well. But there are also press fit implants here. Actually, this diagram doesn't show any cement here. This is just press fit, which means they're just biologically being impacted into the bone. And then over time, the bone and the implant kind of grow into one another, and that forms your lasting, reliable connection. And then ultimately, you'll close the tissue in a multi-layer fashion, starting with your hip capsule, then moving into kind of the subcutaneous space, and then your skin afterwards. Apply post-op dressing, and then really imperative, post-op therapy for total knees is super, super important because knees notoriously can get quite stiff. And so getting patients going early on, encouraging them, making sure they have a good therapy protocol in place is absolutely imperative to a successful final outcome. Now, a bit about the total knee bone cuts here. So just some considerations. And again, some of this might get overwhelming. So please feel free to ask questions along the way if something doesn't make sense. And I'm hoping to just kind of bring light to a lot of these concepts rather than get into the weeds in them too much. So when we talk about the anterior and posterior femoral cuts, some considerations that you may consider. So when you do the anterior cut, if you're too anterior, you're not taking enough bone, that can lead to what's called overstuffing of the patellofemoral compartment. So if you can imagine this patella gliding over the anterior femur, if you don't take enough bone here and you just slap a big thick implant on there, then that compartment is essentially just too tight, and that can lead to limited knee flexion actually, because as they flex, you're going to start impinging here. And it can actually lead to just anterior knee pain as well. Conversely, if you're too posterior, so if you cut this anterior cut too low, you can eventually start cutting into the femoral shaft a bit here at the distal femur, which is what we refer to as notching. Now, a small degree of notching has not been shown in the literature to really affect the periprosthetic fracture risk, but there is literature that supports about, I believe, 3 millimeters or so of notching into the cortex here can actually increase your risk of postoperative fracture. Some other things to consider here. This is kind of a very popular graph, and I think it can be tempting to try to memorize graphs like this, but in fact, this stuff is actually really intuitive if you just think about it a bit. So if we divide our femur cuts into a distal femur cut and then an AP cut as kind of two different entities, and then your tibial cut, you just look at it as one thing, obviously, you quickly realize that if you picture the knee like this, you think about your AP cuts and the position of your implant in this direction, you can see how that would affect your flexion gap or your flexion tightness. Because if things are more posterior, that's going to make this compartment here a little bit tighter in flexion. Whereas if it's more anterior, you're opening up what we call the flexion gap here. Whereas if you picture this femur rotated 90 degrees clockwise, you can imagine how the AP direction is going to be going this way. And in fact, that's not going to affect the gap in that position. So that we call our extension gap. So if you rotate this 90 degrees where the distal femur cut is now articulating with the tibia, that gap we call our extension gap, which is right, that kind of intuitively makes sense. That's the gap that you have in that space when your knee is in extension. And you can imagine there how your distal femur cut, if you take more, would lead to more widening of that space. And if you take less, then that would be a tighter extension gap. Now, the unique thing here is that when you look at the tibia, you'll appreciate that regardless of whether you're in flexion or extension, your tibial cut will affect both. And so if you can kind of keep that general paradigm in mind, all of this actually becomes really intuitive. So if you're tight both in extension and in flexion, well, you don't want to just change one cut or the other in your femur, because as we've now explained, these kind of differentially affect your flexion or extension gap instead of both. But if you cut your tibia, that kind of takes care of both things at the same time. Whereas if you're in a situation where, let's say, you are loose in extension, but tight in flexion, you can cut more from your posterior condyle. So that's going to help loosen up your flexion gap because you're taking more bone here. And then ultimately, when you do this, you can actually make, because you're tight in extension, you can upsize your polyethylene liner to make up for that gap in flexion so it remains appropriate, and then make up that loose extension gap because that poly is, you think of it as just an extension of your tibial cut. So when you straighten the knee, that'll make up that loose space. And so as you kind of go through tables like this, you'll see they're actually quite easy to reason through them once you understand that general difference between what your distal femur cut versus your AP cuts affect, and how your tibial cut affects both, and you can kind of mix and match from there pretty easily. We refer to this kind of whole concept in total knee as your sagittal alignment of your implants, and important things to consider anytime you kind of see as surgeons go to make their cuts during surgery. So coronal alignment, when we talk about kind of varus and valgus alignment of knees, so you have to first appreciate that as the joint and bony deformity progress over time, the soft tissues actually change as well to accommodate this. So with a varus knee, which is demonstrated in these x-rays here, the medial knee is starting to close down and the soft tissues on this space become tight. Conversely, the lateral sided tissues actually start to loosen up. And I think oftentimes it's not uncommon where I think intuitively we want to think of it in opposite fashion, meaning like, oh, well, if it's loosening up here, or if this gap is opening up, wouldn't that tether the lateral ligaments more? In reality, it's more of a chronic process. So the ligaments are actually just giving way over time. And you think about it also, with kind of an easy way to keep this in mind is think about these ligaments, you're considering them referencing what you're going to see during surgery when you're trying to fix this alignment issue. So if you can think about trying to straighten this, then you'll appreciate that you're going to have quite a bit of wiggle room here, but the medial tissue will be quite tight. And a valgus knee is opposite of this, of course. And during surgery, some of this deformity, depending on kind of the surgeon's goals and kind of surgical philosophy, some of this can and will be corrected with both the bony cuts as well as the soft tissue releases. And so getting into like for a varus knee, we think about if you look at the kind of picture the medial side of the knee here, as you start to dissect deeply, you'll eventually, as you kind of peel off the joint capsule from the tibia, you eventually get to the deep aspect of the MCL, and that can start to be released. If there's bony osteophytes on the medial side of the knee, these can be pushing onto the capsule and kind of causing it to balloon out a bit and causing it to be artificially a little bit tighter. And so by removing these, you take some stress off of those ligaments. And you can then kind of take that release further along the posterior medial aspect. You can do what's called a medial tibial reduction ostectomy, which is actually sawing off a little bit of medial tibial bone here, which achieves kind of function the same thing as removing osteophytes. And then you can get into more extreme releases as kind of mentioned here. And there's a similar kind of strategy for the lateral side as well. I kind of deferred putting these on here because you're not going to memorize these with just a one-time look. And in fact, you'll see oftentimes in surgery, you're kind of seeing the first two or three of these more than anything. But just understand the general concept of releasing soft tissues on the tight side of the deformity to try to achieve a well-balanced knee. And I should apologize because I think it was a little bit confusing here because this diagram obviously is a valgus knee. So really you'd be doing soft tissue and bony releases on the lateral side of this knee, just to kind of keep it accurate for what we're showing in pictures and describing. Moving into axial alignment and patellar tracking. So patellar maltracking can be a considerable source of patient dissatisfaction postoperatively. Symptoms for this can include anterior knee pain, feelings of patellar instability manifesting as subluxation, and very rarely frank dislocation of the patella. A couple of key concepts here to appreciate. So Q angle, which is demonstrated by this red angle here in this picture. This is an angle that's formed from a line starting from the ASIS down to the middle of the patella, and then down to the tibial tuberosity, and a line straight up from there. And if you can imagine this angle here, this really represents the force of lateral subluxation, because if you can appreciate, your quadriceps tendon is pulling this patella along the axis of your femur in this way. And so you can imagine there that it's not just a straight up and down pull of the patella. In fact, it's being pulled slightly laterally. And if you have a greater Q angle, that represents a greater lateral pull. And so during surgery, you want to minimize this because the patella typically subluxes and dislocates laterally, just kind of given the distal femur morphology and the presence of this Q angle. Females typically have a slightly larger Q angle, owing to sometimes kind of a greater knee valgus angle and more so actually wider hips. But again, it's just a few degree difference. Getting into this a little bit more. So how do we kind of prevent this? So you have to appreciate this bottom right image here. So if you can look at this left-sided diagram, so medial is on the left here, lateral is on the right, and you can think about placing a femoral implant on the cap of this femur, and think about what would happen if you medially, or in this image, counterclockwise or laterally or clockwise, rotate that implant, and think about how that's going to affect where your patella is sitting. So if you internally rotate this implant or move it counterclockwise in this image, your patella is is going to be sitting relatively more lateral. And the converse is true as well. So you want to avoid internally rotating these implants. Additionally, you want to avoid medializing this implant that achieves functionally the same thing with your patellar implants sitting relatively more lateral. Similarly, when you put your patellar implant on, you want to place that more on the medial aspect of the patella. If you place it more laterally underneath the patella, then that's going to be obviously sitting relatively more lateral within this femoral groove, and that could dislocate or sublux more easily. So these are important steps to keep in mind, and your tibial implants actually do this similar. So if you rotate your tibial implant externally, you can imagine that if you look at actually this Q angle diagram, think about externally rotating your tibial implant. That would move this this point here at the distal end of your Q angle more laterally, and that would similarly be achieving a greater pull on the patella laterally. Ultimately, as you kind of go through your surgery, you keep these things in mind. And then near the end, when you're doing your range of motion checks, one thing you always want to watch is as you move the knee from flexion to extension, is your patella tracking centrally within the femoral groove? So those are kind of some of the basics for total knee. A couple complications here, just so you guys can be familiar with these things. So aseptic loosening is, as the name suggests, a non-infectious process that occurs typically chronically over many years. And this occurs often because over time there can be some debris, some particular debris from the actual implants themselves. And this can induce a macrophage-mediated inflammatory response, which can eventually manifest as bone loss, which can progress to micromotion and eventually even implant loosening and catastrophic failure. So these are actually, these are significant cases of aseptic loosening. You can appreciate this really thin, loosened line that is being shown here by the arrows compared to the absence of that in the immediate post-op radiographs. But eventually, this can actually progress from the implants being grossly malpositioned. And the treatment for this is eventually revising them to new revision style implants, freshening up bone cuts, and basically redoing the surgery again. Arthrofibrosis is a unfortunately common complication of total knees. This is kind of what I was alluding to earlier with the importance of post-op physical therapy and getting patients moving early on. This can affect anywhere from 1 to 10% of patients post-operatively. The definitions, which do have some variation in the literature, are about 10 to 15 degrees of a flexion contracture, which means you cannot fully straighten your knee. You're stuck at about 10 to 15 degrees short of full extension. That's kind of one side of what we would describe as arthrofibrosis, and the other side of it is having limited knee flexion, less than 90 degrees at about 3 months after surgery. This, you'll kind of hear a common thought, which is, what you get in your first 3 to 4 months after a knee replacement is what you'll end up with for the rest of your life. You're not going to gain any more range of motion after that point. And so the treatment for this kind of uses that 3 month window as well. So if under 3 months from surgery, you're demonstrating signs of impending arthrofibrosis, then you can take patients back for a manipulation under anesthesia, which is exactly what it sounds like. Basically, you put the patient asleep, eliminate any of the pain or fear response associated with things, and then just bend the knee gradually through range of motion. And you can get patients actually back to 0 to 120 degrees with this alone. And if it's later on past the 12-week point, most people are doing this, but with an arthroscopic lysis of adhesions, which is where you put cameras into the joint, right? So arthroscopic surgery, and then try to debride any built-up scar tissue, and then do a manipulation under anesthesia, either before or after the LOA. Ultimately, when you do this, though, there's actually a risk of obviously reoccurrence of their knee stiffness, but also there's actually a risk of fracturing around implants, which can be catastrophic. So this has to be done very carefully. Ultimately, a problem that you'd rather avoid altogether, again, underscoring the importance of an appropriate post-op physical therapy protocol, appropriate post-op pain control, and setting expectations with patients. So a lot there for total knee, but I think we covered kind of the main things that I was hoping to hit. Moving on to total hip here. So THA basics, you'll see here, obviously a similar treatment paradigm or surgical kind of paradigm here. You're replacing the acetabulum and the proximal femur by removing the bone and replacing them with kind of similar implants. The difference here is the kind of thickness of the replacements is not the same in the way that we think about it compared to total knees. You can like sink femoral implants in further. You can take them up higher. You can cut at various points. This kind of picture here is to demonstrate a few different terms that you may see. So hemiarthroplasty is not typically done for arthritis. This is something we see sometimes in fracture cases for displaced femoral neck fractures, a very common treatment that is used for that. So this is where you leave the acetabulum alone, but in fact just replace the fractured portion of the proximal femur and put in proximal femoral implants. Hip resurfacing is a bit more of a historical thing that you may sometimes see alluded to or see patients coming in for revisions of this. This is kind of what it sounds like essentially. And then you'll sometimes see these terms called a bipolar, which is so a hemiarthroplasty where there's a ball that sits inside of another ball. So even though you're leaving the acetabulum alone, the actual femoral implant itself has two articulations in it built in, and so that can give you a little bit more stability and range of motion. And then you'll sometimes see a constrained liner mentioned, which is this acetabulum shell here, which is kind of the standard thing. And when we have the polyethylene liner, there is kind of this metallic ring that goes around it that helps keep it it keeps it linked in with the femoral implant, and that can help provide some stability as well. Objectives similar to total knee, with kind of the key differences we alluded to earlier being kind of stability being a big thing that we don't typically struggle with total knees, but really being a key surgical consideration in total hip. And we'll talk about that more as we go. So some native anatomy of total hips. So the hip joint itself is a highly congruent ball and socket joint with really excellent native intrinsic stability and range of motion. Native stability or intrinsic stability, meaning like there's quite a bit of coverage from the native acetabulum and your femoral head sits in that nicely. So that joint is obviously not one that we commonly dislocate outside of the really severe trauma setting. The native acetabulum has what we call about 15 degrees of anteversion, as you can kind of see demonstrated in the top right here, which means it's kind of tipped forward about 15 degrees from this neutral position. And then there's about a 45-degree abduction angle. So it's not a flat to the side cup. There's about a 45-degree angle here. And then the native femur has what we call about 15 degrees of femoral anteversion. This is something that I think is sometimes a confusing concept. So this is basically an angle along the axis of the femoral neck compared to a line drawn at the posterior aspect of the distal femoral condyles. And so basically, just imagine, right, your proximal femur doesn't sit flush with the rest of the bone. It actually has about a 15-degree angle anteriorly. And these are important because when you put in new implants, you want to recreate these to a certain degree. The next shaft angle is about 125 degrees, and then some basic terminology to start becoming familiar with. So leg length, obviously, I think we understand the general concept of that, but how do we assess that? So you can use different points here to assess kind of how far down you are. The hip center is something that we'll see a little bit later on as well. And when you put in new implants, you can be changing this, and that can affect your leg lengths. When we look at our lesser trochanters here, if you put in longer implants, that could actually push the femur down, and that could lengthen your legs. And then another concept here is kind of what we call medial offset, or you'll just hear it sometimes referred to as offset, which is this concept of how far is the axis of the femur from the actual center of the hip joint. And so as you kind of extend this out further, you're increasing their offset, and as you're closer on, you're decreasing their offset. And again, you want to just try to recreate their native anatomy, and this is often templated from the contralateral side. So some concepts and stability here. This is kind of an important thing, and things you'll kind of see thrown around, and sometimes kind of see in like practice questions, things like that. So surgical technique, there are a few different important kind of considerations when we talk about stability, different things that can contribute to stability. So surgical technique, we'll go through the techniques a little bit later. So posterolateral approaches versus direct anterior versus more lateral sided approaches. These can have varying dislocation risks based on kind of what literature you're reading. Component design. So these are I understand probably concepts that are a bit foreign here, but just to introduce some things. So generally speaking, having a larger femoral head is better in terms of stability because that increases the head to neck ratio. And that achieves a couple things. So if you can look at kind of this diagram here on the top left, if you can imagine, if you have a bigger femoral head here, you get a larger range of motion before the neck itself is impinging on the cup. Another kind of benefit of this is you get what's called an increased jump distance. And so if you can kind of imagine the smaller femoral head here on the bottom left, this only needs to migrate just a few kind of units of measurement here before you're fully unseated from the acetabulum. However, if you have a larger femoral head, you just have to cover more space before you're out of there. So I think it's kind of simple when you see it diagrammatically. But these are kind of things where you'll see trying to achieve a larger femoral head during surgery, like why we do that. Skirts are essentially a type of implant design that is kind of as it sounds like, kind of like a skirt at the bottom part of the neck here. And that actually decreases your head to neck ratio. So that can basically flip what we demonstrated on this diagram here. And what these things do is as you kind of range your hip, you'll eventually get to a point where the neck may actually catch onto the acetabulum, and that cantilevers the hip out of place. And that's actually how you dislocate your hip oftentimes. It's not like it kind of just falls out of place. It's more of a levering mechanism. And so if you can imagine kind of a skirt here, or kind of a thicker implant here, that's going to impinge on the acetabular implant at an earlier range of motion. And then elevated and lateralized liners. So you'll see kind of these acetabular liners that go inside this metallic cup. And these can have lips that can help prevent dislocation in certain directions. They can also help you kind of achieve more offset, which plays into your soft tissue tensioning. And so kind of touching on this here briefly. So as you can imagine, obviously we look at these x-rays, it can be easy not to appreciate the soft tissue attachments here. And so there's obviously several muscles that are attaching your pelvis to your femur. And as you can imagine, increasing the offset of your construct, pulling this further away is going to tighten that tissue. And that helps kind of keep things in place better. Whereas if you lose offset, then you kind of have a little bit more of a loosey-goosey joint and something that can more easily pop out of place once it gets caught levering. Component position is important. So there's sometimes some people will tailor this slightly to their approach. So we talked about it earlier, and we'll touch on a little bit later as well, trying to match native anatomy. Some kind of more catastrophic things that can happen. So if you put a cup in very vertically, as you can probably appreciate, this ball is not sitting centered in this cup. It's actually sitting eccentric here. So this is the product of chronic wear eccentrically, and that can increase your chance of dislocation. Versus if you put in a cup too flat, then that can lead to a position where you kind of impinge at an earlier range of motion than preferred. And then soft tissue function is important. So patients with strokes, patients with neurocognitive disorders like Parkinson's that can affect their peripheral nervous system in ways, or patients with even like local pathologies or infections, things of that nature. These can also affect the stability of your overall total hip. So jumping into surgical approaches and steps here. So again, we talked about some of the pre-op stuff earlier. Generally similar treatment paradigm here for hips. Hip arthroscopy in arthritic cases is not really doesn't have any role in its treatment. Whereas, like I said, hip, I think some places will do that for early cases for younger patients. But something that is important in hips is alternative causes of pain. And that's important in knees as well. Sometimes you'll see arthroplasty surgeons talk about anyone with knee pain should also have their hip evaluated because some patients can refer pain towards their knee from hip arthritis. But I will say, at least in my experience, I think trying to differentiate between that is less common than patients with back pain that can have radiating pain toward their glutes, and that can be manifesting as hip pain as well, and kind of cloud the picture a bit. And they can have both as well. But things to try to tease out, because if you take a patient back with really mild arthritis because they seem like they're having hip pain, but in fact they have a really bad case of degenerative disc disease in their back and spinal stenosis, for example, then they may not get the pain relief they hope to get from their hip replacement. Various arthritic etiologies, so unique to the hip is kind of cases of avascular necrosis, when you'll see this really kind of striking hip deformity that can occur pretty rapidly, in fact. But other than that, kind of similar, obtaining weight-bearing radiographs, setting expectations, and then templating in total hips, I think is often a more commonplace than you see it in knees. What templating allows you to do is kind of see, one, get a general sense of how big of implants you're going to be able to get into this patient's native pelvis and femur. And then two, depending on kind of where things are sitting as you template them, you can expect or even aim for different amounts of offset or different amounts of leg length changes based on kind of how you're templating things. And again, I don't want to get too far into the weeds of that, but just know kind of there's the general role of templating and the benefits you can get from that. So steps and approaches here. So there are four commonly described surgical approaches. The two that you'll probably see much more commonly, at least for elective arthroplasty, is the direct anterior approach and the posterior or posterolateral approach. We'll touch on those a bit later. There are, overall, I think outcomes far and away are actually pretty similar, but there's just pros and cons to each, and we'll touch on that later. A lot of it is surgeon preference and training and kind of institution dependent, but understanding the hip is a deeper joint than the knee, so really a careful approach is crucial in this instance, and it can be actually quite difficult to do the surgery with, like, you can get further along in a hip surgery and realize that your approach was inadequate because you didn't kind of appropriately release things along the way. Whereas a knee, it's like once you're kind of open and seeing things, pretty quickly if you're where you need to be. So basic steps here, you'll do your approach, you'll cut the femoral neck, you'll then what's called prepare the acetabulum using a reamer that's demonstrated here in this top image, kind of like a cheese grater type of device that roughens up that surface and creates kind of a more symmetric cup where your acetabulum is going to be seated into. Then you'll actually put in acetabular implants and a polyethylene liner. And then you'll follow that by doing your femur afterwards. Typically, femoral preparation is typically done what's called broaching, where you put in these implants and you like sequentially upsize them. So you'll start with real small and thin ones, and then go up higher and higher and higher until you get to a point where these things are sitting really securely into your native femur. And then you'll trial those implants and then again move to final implants to follow. As you do this, oftentimes when you're trialing implants, and you'll see, especially with anterior approach total hips, you'll oftentimes see this done with radiographic guidance. With posterior hips, people will take radiographs intraoperatively as well, but it's a little bit more difficult, and people may just do kind of like one or two still shots versus in anterior hips, you'll kind of see this kind of a little bit more readily available. And it's kind of a matter of trial and error a little bit. So even though you're templating things, ultimately you get live intraoperative radiographs and try to make sure that you are matching their contralateral side. Keep in mind, obviously, their other side may have arthritic changes. It's not severe in this example here, but if they really have a shortened extremity on the other side because of severe arthritis, you may consider lengthening their limb a little bit with the expectation that you'll kind of match that on the other side later on. And there's various programs that can actually help kind of shoot out numbers in real time. There are robotic systems that can help with this as well. This is kind of the general thing that you'll see. And then closure and postoperative course. So similarly, multi-layer closure. Difference in this is like the hip capsule closure. I mean, you close the knee capsule obviously every time as well. But what has been shown in the literature a bit is that the dislocation risk with posterior hips, which is kind of a classical risk with that approach, that can really be mitigated with a nice, robust repair of your hip capsule and structures on your way out. So just really paying attention to that both during your dissection and then on the way out with the closure as well. What's kind of unique to hips is most people with total hips really get great range of motion. It's not as difficult to achieve that, but these patients, again, suffer from instability more so. So they are taught what are called hip precautions, which are just positions to not put their leg in to avoid the situations where their implants are going to be impinging on one another or kind of in positions where they may eventually end up popping out and dislocating. So this is kind of a crucial aspect of the physical therapy and patient education process. So a brief word on hip approaches. So again, the four most common: direct anterior, posterolateral, or direct posterior, direct lateral, and anterolateral. I'm going to really focus on DAA and posterolateral here. So the direct anterior approach, eponymously known as the Smith-Peterson approach, this is what we call an internervous plane, which means that you are passing between the tensor fasciolata and the sartorius, which are innervated by different nerves, right? So the TFL is innervated by the superior gluteal nerve, and the sartorius is innervated by the femoral nerve. And then as you get to your deeper interval here, you'll start passing through, or in between, excuse me, your gluteus medius and your rectus femoris, which are innervated similarly as a superficial layer. And the kind of benefit of this is that it can be beneficial from a pain control standpoint because you're kind of not violating any muscles themselves. This approach has also been shown to have some lower dislocation rates classically, maybe some less pain medication loose, earlier function, less muscle damage, less length of stay in the hospital. Cons, this can be a little bit more technically demanding. It's a smaller approach. You get a more challenging femoral exposure. You're kind of working into an awkward angle at times, and that can have some risks for fracturing the femur during surgery. This area in more obese individuals can be problematic and pose an infection risk because they can have kind of a soft tissue pannus with kind of adipose tissue hanging over that area, and that can obviously create kind of a difficult wound healing situation. The lateral femoral cutaneous nerve is at risk during this approach classically, and very rarely there could be a risk to the femoral neurovascular bundle anteriorly as well. That can happen kind of during retractor placement as you open things up. So the posterolateral approach here, known as the Moore, Southern, or Coker-Langenbach approaches, this doesn't have a true internervous plane, but it's more of an intra or intermuscular plane where you're, after you kind of go through your fascia lata and kind of feather over your vastus lateralis, you will actually cut through the gluteus maximus. You'll split those fibers and then get down to your short external rotators here posteriorly. And then you'll actually transect these and peel them back to reveal the hip capsule and acetabulum here, as you can see in the bottom right. The pro to this, so this is kind of the classical tried and true method of doing total hips. Certainly in many hospitals, many surgeons are using this as their workhorse approach still. I think the literature has supported that there's been a migration towards anterior hips and they're getting more and more common, but you'll still definitely see quite a bit of posterolateral approach out there. This is a nice extensive approach with nice exposure to both the femur and the acetabulum, and it doesn't violate the abductor mechanism, which is something that you can see with lateral or anterolateral approaches, and that can lead to a Trendelenburg gait or hip abduction weakness postoperatively. As a cons, again, classically, this has been shown to have a little bit higher of a dislocation risk, although I think more modern literature and approaches have mitigated that. The post-op hip precautions for posterolateral hips are a little bit more rigid than the anterior ones. And then, because it's a little bit bigger of a dissection, you're going through muscle a little bit more, they can have a little bit of a slower recovery early on. And as mentioned, I mean, the direct lateral, anterolateral approaches, you're going through the abductors, which can have some issues, but classically, these have been shown to actually have some of the lowest dislocation risks postoperatively. So some words on implant position and fixation as we kind of wrap up here. So we talked a bit about the native anteversion and inclination of the acetabulum. So you're trying to recreate these when you're putting in your implants. The height of your acetabular implant is important. So as a kind of a general rule, you try to aim for the inferior border of it being near the teardrop, which is kind of this radiographic mark that you can appreciate here. The depth of how deep you're putting in your acetabulum is important. If you put it in too far, you can actually perforate into the pelvis rarely, or kind of lead to some bony overhang from the residual acetabulum. Whereas if you don't medialize far enough, then one, you can have too much hip offset, which is good from a stability standpoint. But what ends up happening is you may not really be able to seat enough of your cup and may be sacrificing a little bit of fixation by not getting enough kind of bony contact to this acetabular shell. You sometimes will see this diagram. So some people will put in screws into their acetabular cup to help provide some more fixation. There are kind of these classical safe zones and unsafe zones or danger zones where you can put in screws, where like if you kind of put a screw in that's too long, you can really damage some critical structures. Moving into kind of the femoral position and fixation. So again, you want to try to restore your medial offset when you put this in. This can be achieved with like different neck length. So when you put in many femoral implants, you'll see like they make them with different stem sizes as well as different neck sizes, which can actually have what are called kind of high offset or standard offset, which kind of changes the angle a little bit and offers some differences there. And then actually when you put in the ball on top of this, they have different lengths of that ball as well, which you can use to adjust your offset and leg length as well. When it comes to kind of fixating this into the femur itself, so the acetabulum is almost always a press fit in the primary hip arthroplasty kind of situation, but femoral implants are a little bit more split. There are many, many companies and many systems now use what's called a press fit or biological fixation. It just means like the implants are designed in a way to maximize the chance of bony ingrowth and ongrowth, which essentially means kind of what it sounds like, the bone growing into this porous setting or kind of growing around and on top of this roughened surface. Or you can use what's called cemented fixation, where you may use kind of a more smooth implant, but use the bone to act as a grout to kind of catch and capture on and attach into the bone around the implant, and then really encase the implant in a stable fashion. This is typically used for like, in the elective arthroplasty space for like older patients. You may come across what's called the Door classification, which kind of explains the proximal femur morphology. Some people have really osteopenic bone and have what's called kind of a stovepipe femur, where it's kind of almost like a rectangle in shape. And so for those patients, you can kind of see the risk of trying to put in kind of this wedge style implant that achieves its fixation in the metaphyseal region. And so you may not be able to safely get to something like that without having a risk of fracture with really thin cortices. And in those cases, cement can be beneficial. And these are kind of some different stem implant designs that just kind of really to highlight the variability in this. Again, the big thing with this is kind of be familiar with some of the terminology that gets thrown around, and just appreciate the differences that exist out there. And know that like these things really go hand in hand with how you do the surgery as well and what your goals are intraoperatively. So some non-infectious complications here. So we talked about instability and dislocation. Not much else to say on this at this point, other than it's kind of just a residual issue. First-time dislocators can often just be reduced in the emergency department or operative setting under sedation. But typically, once you're reducing more than once and certainly more than twice, oftentimes I think many may opt to do some kind of revision arthroplasty for that. Certainly, if there are kind of obvious implant issues that could have led to that, I think people are jumping to that even sooner. Periprosthetic fracture can be a really challenging issue. So intraoperatively, they're rare, but they do occur from time to time. This kind of happens when you're putting in your implants or broaching for your implants. Very rare in the acetabulum, but in the femur, you can see it sometimes occur. Post-operatively, this can happen after ground level falls. And just a classification system that I think is worth familiarizing yourself with is not the intraoperative Vancouver, but definitely the postoperative Vancouver classification system, because that is kind of one of the few that we have in ortho that dictates your treatment. And once you've kind of classified things, they often will treat it with the form of ORIF using various constructs, with or without kind of revising to new implants to achieve a different form of fixation, as we kind of alluded to earlier. And then kind of wrapping things up with some infectious stuff here. So prosthetic joint infection is kind of the bane of existence of the arthroplasty or even generalist orthopedic surgeon that's doing any volume of arthroplasty. This really can be a significant source of morbidity and mortality. The risk is higher when you're already doing revisions, so something to be mindful of. Um, and again, even like 1%, 2% risk, this is like a massive area of both orthopedic research and like industry focus to try to just minimize this even below 1%, as low as we can, because these are just devastating complications. So oftentimes, patients can have varying degrees of concerning symptoms, or kind of new symptoms that present after a well-functioning joint before, and oftentimes this is an indication to do a aspiration. You obtain crystals, cultures, gram stains, cell counts, and there are different kind of criteria that have been published. This is the most recent MSIS criteria from 2018 that has kind of been popularized in recent years as ways of kind of prognosticating your risk of infection, with different findings from both serum and aspirations, as well as kind of, if you see a sinus tract, a gross sinus tract, that's like basically an indication that it's an infected joint. Non-operative management outside of kind of the really chronically debilitated or kind of hospice setting almost in a way is rare. I mean, certainly some patients may opt for that, but it's almost never successful. Not something you'll see very often. Now, if someone has like a multiply revised joint with really extensive revision implants, sometimes that can be kind of a reason to do it. But again, not something you see often. Operatively, kind of the general treatment paradigm is there's something called a DARE procedure, which is a debridement, antibiotics, and implant retention, where you basically keep the metal implants, but you change out this plastic poly because that's a modular implant. And you just debride all the tissue around there really, really diligently. The catch with this is typically this is only indicated when it's kind of a very acute infection. And then also the uh, kind of actual isolated organisms can play a role in this as well. So really more pathogenic or aggressive organisms have been shown to fail this more often. And then the gold standard in the US still is two-stage revision arthroplasty, which involves removing all of the implants altogether, placing these temporary implants, what we call cement spacers, and then placing patients on about 6 weeks of IV antibiotics, taking what's called an antibiotic holiday, just taking them off antibiotics, and then obtaining follow-up labs to make sure the infection's been eradicated, and then taking them back in for a second planned surgery to revise to brand new clean implants. One stage revision is something that is more popular in Europe, and it's kind of been making its waves into the US a little bit. And this is where you, as the name suggests, just do everything all in one go. But again, this has been shown classically to be a little bit less reliable in terms of eradicating the infection. And so still, I think kind of book answer in the US is two-stage revision for any infected total joint. All right, we're coming in just basically at an hour here. Thank you guys for hanging in there. I know that was a ton of information. Hopefully that kind of provides a really nice overview of really all the big basics for knee and hip. The goal of this is like this is something that you guys can if you kind of took some notes here, or if we end up sharing this PowerPoint, something that you can kind of just keep in your back pocket as kind of a really quick, rapid review of big things that if you're looking to prepare for a case and you're like, okay, well, what are some things, some ways to start off? Like these are kind of some of the good big things to look into. So with that, I'll just kind of open it up to questions here. I'm happy to hang out here for about 10 or 15 minutes if anyone has any questions.
Hey, Dr. Talle, just wanted to say looking forward to seeing you at the conference coming up, and thank you. This was a great educational experience.
Yeah, absolutely. Appreciate it, Nick. I'm looking forward to hanging with you guys there. Um, if there's any feedback on this presentation or how we can kind of do it better in future years, then please also don't hesitate to reach out to me via email. I think that was mentioned in kind of some of the SAO emails, or at least my email was provided. But I'm definitely happy to know this was a big talk and something that um, I was a little bit on the fence about whether we'd be able to hit both in a timely fashion. And so if you felt like this was just way too much information for kind of a one sitting thing, then please let me know. I'm happy to kind of help adjust this for future presentations for y'all. But if no other questions, then we can let you guys go. Let's see, there's something in the chat, maybe. No, cool, cool. Yeah, of course. Miraco, if I'm pronouncing that right. My pleasure. Hope you guys are doing well in your third and fourth year rotations. And best of luck if anyone here is pending the match. I know Jermaine's got it coming up here in a couple weeks.
Thank
But
you.
hopefully we'll see you guys at SAOAO. All
All right, thank you, AC.
right, guys.
Thank you, Dr. Tully.
Yeah.
Thanks. Have a good night.
All righty, guys. Have a good night. Sure.